Good afternoon. Before beginning my oration this afternoon, I would like to pay a personal tribute to Dr. P.C. SANYAL. Dr. P.C. SANYAL was born in October 1899 in Mymensingh, now in Bangladesh. He graduated from the Medical College in Calcutta in 1926. After this, he went to England for training and higher studies. He passed the LRCP and MRCP England in 1931 and then passed the FRCS in England in 1934. He was connected with the Sri Aurobindo Ashram Pondicherry, a place to which I've been on 2 occasions, even before this, as is evidenced from the fact that when he registered his postgraduate degrees in the Register of the Bengal Council of Medical Registration, he gave his address, care of Aurobindo Ashram Pondicherry in India. In Calcutta, he was appointed as Honorary Junior Visiting Surgeon to D.C. Chakravorty, the then Professor of Clinical and Operative Surgery, Medical College, Calcutta. For some years, he then worked as a paediatric surgeon in the Medical College Hospital for some time. Immediately with independence, there was a change in the Medical College. Dr. SANYAL was appointed as the Professor of Clinical and Operative Surgery in the Medical College, Calcutta. Dr. B.C. Roy, Chief Minister of West Bengal, introduced a new setup. Dr. SANYAL was appointed as the Professor of Surgery, the Medical College, Calcutta, in July 1953. He resigned from the post and left Calcutta for good to his permanent abode in Sri Aurobindo Ashram Pondicherry. There he wrote a book in surgery named Surgical Text. He led the life of an ashramite and died in July 1978. Good afternoon. My name is Byrne. I am the Global and International Director at NHS England in the UK. NHS England is the oversight body which oversees the delivery of the UK's brand of universal health coverage, the National Health Service, which celebrated its 75th anniversary on the 3rd of July this year. Having travelled to India personally over 50 times over the course of the last 30 years, I'm really devastated not to be able to join you today. I was looking forward to coming across as recently as last week, but unfortunately, owing to industrial action and some pressures within the NHS in the UK, I've been unable to travel. What I'd like to talk to you today really is my own personal belief and experience of international partnerships and their value in solving the really big issues that are facing healthcare today. Thinking about those issues, we all know that we have a massive shortage of healthcare workforce. The WHO have made this clear repeatedly. The gap between access to healthcare and the quantity and quality of workforce is not rapidly reducing, and we know that this is a major issue. We have also learned from the pandemic that global health security poses an ongoing threat, and we were not really as prepared as we could have been for the threat that COVID-19 brought to our populations. In addition to this, we recognise that it is no longer or never has been satisfactory that there is massive inequalities in access to healthcare, and inclusion and participation both in terms of access to healthcare and in those who deliver healthcare is becoming increasingly important, particularly to develop pathways for innovation. And finally, the biggest threat of all, as the planet gets warmer, we need to recognise our responsibility to act in a positive way to defend the planet and its people from global warming. One of the things that we have learned from the pandemic is that the verticalisation of healthcare, in other words, working within one's own country in isolation, is an absolute disaster. And the UK demonstrated that quite powerfully, really, with some of the worst impacts of COVID-19 in the early stages of the pandemic, where we made political decisions to look at our own populations rather than extending and recognising that the issue was a global issue and could only really be tackled if we dealt with our partners in a very systematic and efficient way. The UK has been incredibly lucky having the oldest and largest universal health coverage system in history. Nevertheless, our challenges are great, and without any question, one of the big problems of being so old is that we need a constant renewal and transformation, and we're in a period at the moment where we're clearly not delivering against the demand. Our workforce has increased by 20% since 2010, and yet there are still 7 million people waiting for elective treatment out of a population of 65 million. We are still working with underneath the auspices of a paradigm of a therapeutic access to care rather than a prevention and public health approach, preventing people from needing healthcare in the first place. We know from our own experience, and this is true elsewhere in the world, the overwhelming majority of caring actually for our populations is done at home and is unpaid and untrained. And we in the NHS, in order to adapt to demand, have moved from a employer which employs 50 different professional groups to an employer which employs 150 groups, professional groups in 2021. The total proportion of our international workforce working within the NHS, which has always relied on the influx and efflux of international graduates, has doubled over the course of the last 20 years. And because of the global workforce shortage, I suspect that undersupply is the greatest risk facing social care and health care services across the planet. For those of us who trained many years ago, I graduated in 1989, I recognise that many, if not all, of the practical and pragmatic skills that I learned in that period are no longer relevant. And actually, we talk about this particular diagram as the cone of uncertainty, is that we train healthcare workers a generation or so before they start to take real impact in the direction of healthcare, and by that time the skills that they learn have changed dramatically. Therefore, our future workforce cannot be the same as the workforce we have already trained. We can no longer rely on a super specialism and the artificial division between primary, secondary and tertiary care. We have to start and increasingly focus our educational and lifelong educational programs, both at undergraduate and postgraduate level, on learning metacognitive and adaptable skills that will allow us to adapt to whatever changes are around the corner, which we don't yet know. We probably need less specialists as a proportion of the overall numbers of doctors and allied health professionals, and more generalists to enable us to deliver healthcare where it is required. We also need to understand how technology can enhance rather than detract from healthcare delivery, and we need a more diverse and more equal workforce. What is really strange is that whilst countries have common themes in terms of what they are requiring at the moment, like workforce, like ageing populations, etc., there are also significant differences. In the Kingdom of Saudi Arabia, for instance, they have a very cash-rich but human resource poor economy, and the response to that in over the last couple of decades has been to attempt to purchase that healthcare from abroad, and that policy has fundamentally failed to deliver the universal health coverage that they require. In Africa, we have a situation where the trained human resource is poor, but the clinical exposure and opportunities for learning is very, very high. In India, state by state, you have very population rich. You have masses of trained workforce, yet healthcare delivery is highly variable. In the USA, they have a cash-rich scenario, but because of the success of healthcare the population has aged and therefore been unable to catch up training enough healthcare graduates to deliver the healthcare demand that's required by their population. And then ourselves in the UK, we have the NHS, which continues to promise and deliver healthcare free at the point of contact. But we are recognising increasingly that without transformation and a shift in the way in which we do things, our healthcare will be not only unaffordable, but will diminish in quality over the years. So we at NHS England and in the wider NHS recognise now that the big solutions have to involve engaging with our partners. And I want to talk to you really about how partnership can improve supply, how it can improve the quality of our healthcare professionals, how it can enhance education, and how it can promote innovation. And I also want to mention that we have experts in our midst, really, who we do not use appropriately, and they are the diaspora organisations who've already worked in more than one healthcare economy, and the need for us to understand their experiences and to use those experiences for healthcare transformation in the places that we all live. So in my own unit, which sits within NHS England nationally, we talk about partnerships at three levels. One is the relationships, both formal and informal, between healthcare workers, whether they be managerial or clinician frontline workers, their relationship. The next form of partnership are partnerships between institutions or places, large-scale institutions in India, like the Kolkata Medical School and medical schools within the UK, and then overriding all of this, government-to-government partnerships. The first example of a partnership that I want to describe is one that was brokered between the UK government and the governments of St Vincent and the Grenadines, a relatively small island in the Caribbean. Health Education England, who were an executive arm's length body of the Department of Health, were approached by the Prime Minister of St Vincent and the Grenadines, pictured in this picture, in the centre of this picture, Ralph Gonzalez, because over the course of the preceding decade, St Vincent's had overtrained its number of nurses, and there were a significant proportion of the nursing population that were unemployed. He was also really keen on upskilling his own nursing staff and proposed an earn, learn, return type programme, which we established with Leeds General Hospital in the north of England. In 2019, we took 30 nurses from that island and placed them in Leeds on a 3-year earn, learn and return programme. And then in 2020, when the pandemic hit, we reversed the process and we shared nursing skills and human resource in the other direction with St Vincent's and the Grenadines stop. Now we have an annual round table to discuss the workforce plan for the partnership on a year-by-year basis. And this year, for example, we're looking at upskilling diagnostic radiography and allied health professionals on the island. And the partnership is mutually beneficial and well received by both parties. The second partnership I wish to describe briefly is a peer-to-peer partnership between the UK and multiple global partners. For the last 6 years, we have been increasingly recruiting healthcare workers who are both managerially trained and clinical trained to take career breaks where we place them on leadership development programs within our partner countries. We currently have fellows in some 11 countries across the globe and are looking to create fellowships in India from the middle of next year. These fellowships are relatively unique in that we identify high-flying candidates from the health system and then coach them in leadership skills and quality improvement methodology, and then work with our global partners to place them into a area where they can produce a definitive programmatic piece of work to improve health systems in the partner environment. In a similar fashion, we are welcoming several hundred international healthcare graduates, medical, allied health professional and nursing, for them to work and train with us within the system on earn, learn and return programs. Perhaps the most commonly used pathway for this is the medical training initiative, which currently has 2,000 international doctors from low and middle income countries on 2-year fixed visas who come and work with us for that period of time as mid-grade doctors to return back to their own countries for the purposes of working with home-trained doctors and improving local healthcare systems. The next partnership is an example of a institution-to-institutional partnership which we have established with the help of the British Council and the Indian Embassy. This is a programme between Manchester Mental Health, London Mental Health and West Bengal. We have been working with the nursing school in the Calcutta Medical College to upskill nurses in terms of delivery of mental health diagnosis and treatment within rural communities. This programme was sponsored by the UK India Education and Research Institute, which is a jointly funded project with the British Council and the Ministry of Skill Development. To date, we have developed 17 master trainers and had over 400 trained nurses go through the programme. We've co-developed a series of training materials and have published quite extensively in peer-reviewed journals on the success of the programme. The final partnership programme is a much bigger one, which sits within the unit that I oversee. This is the NHS Consortium for Global Health. This was established in 2018 as a strategic partnership with funding from our Foreign, Commonwealth and Development Office. The Consortium for Global Health provides a single point of access to the UK's national health organisations, and we work with UK government to foster effective peer-to-peer health alliances at all levels across the UK. The consortium consists of multiple partners, including NHS England, NHS Resolution, the Care Quality Commission, the UK Health Security Agency and the National Institute for Clinical Excellence, all working together with partner governments and partner regions to look at mutual benefit health system strengthening. To date, we have mobilised over 2,200 hours of NHS expertise, delivered fundamentally through a model of collaboration and quality improvement. We have access to 220 subject matter and leadership expertise who we mobilise to work with other countries, and we've held over 130 bilateral and multi-country knowledge exchange events. So, in summary, I do believe that most of the big issues in health can be solved through partnership, whether they promote circular migration or ethical, educationally based exchange, whether they promote global health security, whether they promote inclusion and participation, or whether they arm our healthcare workforce to be champions to protect the planet against the effects of climate change. The final thing I want to say before finishing is we as the NHS have relied really heavily on our migrant and temporary population in terms of delivery of our universal health coverage through the NHS. We haven't always terribly recognised exactly what benefits these group of staff build, and my unit is now launching on a positive drive to empower our diaspora communities to help us change our brand of universal health coverage into a brand which is fit for purpose for the 21st century. So I would argue that a partnership has great power in changing the way in which we deliver our healthcare and prevent populations from developing avoidable illness. I'd also like to point out that perhaps the single biggest and strongest partnership that the UK has had in healthcare is with India. And I think we have a real opportunity to develop and enhance those partnerships as we move forward. And I'm really grateful to Professor Ditendra, who worked with me over 20 years ago, learning about oncoplastic breast surgery, and his enthusiasm to develop really strong partnerships with my team at the moment. So I'm extremely grateful for the honour of presenting to you today. And I just leave you with this thought that over the last decade, there's been a fundamental shift in thinking that no longer sees development purely in terms of aid or something that happens exclusively in developing countries, but to one of mutual and respectful engagement and partnership to tackle common challenges. Thank you.